So I'm going to talk about living well with amyloidosis, particularly in WM. I thought it'd be useful just to talk about what is amyloidosis, because it's a rare condition. It can be difficult to find information about it online, and also particularly associated with WM or IgM-related disorders is even harder to find reliable sources online. I think it's useful to have some information about specifically what it is, and then navigating some of the challenging diagnostic pathways in the UK, but also abroad can be quite difficult. And it's helpful to know a little bit about how that is achieved. And then finally, discussing what treatments are available. So I'm trying to make this interactive. So the first question is, how many of you in the audience have been diagnosed or investigated for amyloidosis? If you could vote. Okay, so I have someone in the audience, but that's fine. So the first question is, what is amyloidosis? So it can be a bit of a confusing term, but it's a condition caused by proteins that misfold, and they're insoluble proteins. They can deposit in different organs and cause problems with your organs. And there's lots of different types of proteins that can cause this, over 35 different proteins that have been classified, and the numbers are increasing over time. So there's lots of different terms you may have heard of. The most common AL amyloidosis, light chains that you will have heard of associated with WM and other hematological disorders. But amyloid proteins are associated with other diseases, and these are proteins that have become misfolded. They form abnormal fibrils, and they cause problems with your organs. So AL amyloidosis is a condition which we think of as caused by abnormal cells that we typically find in the bone marrow when we take our samples. And these form abnormal light chains, which then secrete, which abnormally misfold, and then they deposit in different organs. And the ones we think of as most predominant is in the heart. So having abnormal folded deposition of sticky protein in the heart means that it's difficult for the heart to contract properly, and that can cause a number of different symptoms. But as well as the heart, we have to think about other organs, so the kidneys, the liver, the spleen, and other organs can also be affected. So the next question is, which of these organs can be affected by AL amyloidosis? And it's not really a test, it's just more to see from the audience what the knowledge is. So we've got a good mix there. So we've got the heart, the kidneys, the nerves, lungs, skin, gut, and no points for the brain. So this is all correct that different organs can be affected, and any organ except for the central nervous system, so the brain and the spinal cord, can be affected in AL amyloidosis. We often focus on the heart when you see clinicians, but these other organs are affected, and particularly in WM and IgM-related disorders, some of these other organs are predominantly affected. So the next question, can AL amyloidosis cause Alzheimer's disease?
Is it a trick question?
No, not a trick question. And the reason why I mention this question is because that I have actually heard this a few times in clinic, and because amyloid deposits are seen in some of these neurological conditions, and including Alzheimer's, people do ask, is this related to AL amyloidosis? And the answer here is no, which is the majority of people have answered. But this is a different type of protein that causes the problem. So in AL amyloidosis, you don't have disease which affects the brain or the spinal cord itself. And that really brings us to the symptoms. Because it can affect a number of organs, the symptoms can be quite varied. And this can cause diagnostic challenges because the symptoms are varied, and you may attend with symptoms that have been going on for a number of weeks or months, and then you see a general practitioner, and then it's quite difficult to determine exactly what's the cause behind this. If we take, for example, the heart, we think about the amyloid depositing in the heart causing difficulty with pumping and also causing potentially problems with the heart rhythm, and that can cause symptoms of heart failure. So patients can have unexplained shortness of breath, palpitations, fatigue, and generalized exercise tolerance has declined over time. We think about the kidneys as another major organ. That may well cause some swelling in the ankles, may cause abnormal blood tests when you're having your kidney function tests. The peripheral nerves can also be affected, and that can affect tingling or numbness or pain in the fingers or the feet. Some people have abnormal blood pressures when they're sitting and standing, causing lightheadedness. Occasionally, you can have gut abnormalities, and then soft tissue swelling, which classically people see as a big tongue, swollen tongue, is a sign that we see in patients with AL amyloidosis. But you can have swellings in other soft tissues as well. And really, it can affect any of these organs in different proportions. We think the majority of patients will have heart involvement generally, and then the second will be kidneys, and then a smaller proportion affecting other organs. We talked about the nervous system. So you have the central nervous system, which is the brain and the spinal cord, and then you have the peripheral nerves. And in AL amyloidosis, you can have the peripheral nerves that are affected. And specifically talking about the peripheral nerves, this is a bit of a challenge in WM because we know that peripheral nerves can be affected for a number of other reasons. And even outside of WM, you think peripheral nerves and neuropathy might be related to diabetes, to do with vitamins being low, maybe related to age, as well as medications that can be quite toxic. So you have to think quite widely when you're investigating for neuropathy what the underlying cause is. And it can take some time before it can be proven perhaps that there's amyloid that's sticking to the nerve, because you have to rule out all these other causes. Within the WM world, there may well be other conditions that can cause neuropathy. So less commonly, there can be disorders such as anti-MAG neuropathy you may have heard of. Cryoglobulins in cases can cause neuropathy. And then we've heard earlier about very rarely the cells affecting the central nervous system called Bing-Neill syndrome. But that can also affect the peripheral nerves on occasion as well. So it can be diagnostically a challenge to get to the bottom of specifically what's causing the neuropathy. And this, unfortunately, does lead to late diagnosis being relatively common in this condition because there's not one quick diagnostic test that can be done. Instead, you have to do a battery of tests to try to determine is there amyloidosis and what organs are affected. So in the UK, we have the SAP scan, which is performed centrally in the National Amyloid Centre. And that's a scan that uses a label tracer, which then deposits where amyloid is in the viscera. So we can see if there's renal uptake, spleen uptake, liver uptake. It's pretty good at detecting those organs and not so good at detecting other forms of organ involvement. You may have heard of a DPD scan, which we have. So that's looking for not the AL type, but the hereditary forms of amyloidosis. And that can, I've just shown a photo here of the TTR, which is one of the hereditary forms. The TTR wild type here, which is to do with age related. That's been picked up in the heart, whereas a patient with AL, there's no uptake in the heart when you look at the DPD scan. So again, if you're referred for possible amyloidosis, patients are typically seen in the amyloid center where they would have these scans, alongside looking for any involvement of the heart. So a jelly scan, an echocardiogram of the heart, looks at the thickness of the septum in the heart. So with no amyloid here, we can see a normal thickness of the septum when they do the ultrasound scan, and then a thickened septum here with the patient with amyloid, because that's the amyloid is infiltrated into the septum. This coloured map here shows how well the heart contracts, and there's a typical pattern that's seen in patients with amyloidosis, which is the contraction is impaired and it tends to spare the apex, but it does affect the other parts of the heart. And that gives us a very good indication that there may well be amyloidosis. Now, these are all good signs to say, well, we are concerned that someone's had symptoms of heart failure or shortness of breath, and they have some investigations which look like there's amyloidosis, but we really have to prove what type of amyloidosis is there. So a cardiac MRI is another way of just giving you a clue that there will be amyloidosis because of the thickened heart. And they can inject a gadolinium, which then gives us a pattern of enhancement when we look at that, which is consistent with amyloidosis, if that's indeed the case. But what we really need is confirmation of the disease, and that has to be done histologically. So you have to take a sample of it, send it to the laboratory, and actually find and classify the amyloidosis, because there's different forms and the treatment is very different according to which form you have. So typically you can take a sample of subcutaneous fat, a fat pad biopsy, which is done in the clinic with a simple needle local anesthetic, take some of the fat, and that can be sent to the laboratory, and that can be looked at under the microscope with some special stains to see if it stains positively for amyloid. And that's one way, which is reasonably non-invasive. It's a reasonably simple procedure, and that can be done quite safely. Now, if that's negative, but we really strongly think that this could be affecting the heart or the kidneys or the nerves, the next step is normally to do a biopsy of one of those organs. So we don't tend to do that first line because there's better non-invasive or less invasive ways of doing that. But it may well be that the organs need to be directly taken a sample of if we really need to find the amyloid deposition. And then we have some tests specifically to look in the laboratory to confirm the diagnosis of it. So under the microscope, you can see a special Congo red staining of the amyloid deposits. And then under certain light, it gives a characteristic apple green birefringence, which is characteristic of amyloidosis. And then to specifically type the amyloid, so that's really looking at, is this a problem with the light chains, and is it one of the kappa light chains or the lambda light chains causing the problem? Further tests are done with stains, and also we have more recently mass spectrometry, which looks at specifically trying to find the abnormal light chain, which is helpful for diagnosis and testing response to treatment. So establishing diagnosis can be challenging because there's, as I've said, quite a few steps to get to the pathway. The symptoms can be quite varied and difficult to pin down specifically which is causing which. But when a diagnosis has been made, there are treatments that are available, and certainly in the majority of cases, these would be discussed in the UK at the Amyloidosis Centre with the local team, but also with your local haematologist. And in the world of WM, there's some specific things to think about in terms of discussions with the team. The first question really is, are there features of amyloid affecting one of the critical organs, which we think of in systemic amyloidosis, affecting the heart, the kidneys, and it's affecting the organs around the body? Or is this type of amyloidosis that's just localized, that's affecting just one of the organs, and it's not going to progress to one of the critical organs? That's kind of the first question that needs to be answered. And the way that that's answered is looking at the pattern of organ involvement, as well as some battery of blood tests, which look at the heart, the kidneys, the liver, and as well as the biopsies that we've talked about. Just to briefly mention localized amyloidosis, this is more common in the world of WM, and this could be just soft tissue enhancement, or it could be just affecting the lungs, affecting the skin, affecting the bladder, affecting the eyes, and this is treated very differently to systemic amyloidosis, which affects the heart and the kidneys. Typically in the localized amyloidosis, people can be observed for a period of time and monitored closely, and there are a number of tests that can be done to look for other associated disorders. However, those with systemic amyloidosis really do need to start chemoimmunotherapy. So if we remind ourselves about the process in which amyloidosis develops in WM, we think of the abnormal cells in the bone marrow, which produce the IgM protein and the light chains. The light chains misfold, they form these fibrils, they deposit in tissues. And really what we try to do, the body tries to get rid of these abnormal deposits and fibrils in the tissues itself. So it tries to recruit some of its immune system to get rid of it. But if you're producing too much of this abnormal protein, it's really never going to win. We can never get rid of the amyloid that's already in the tissue. So one strategy is to stop the production of the amyloid being produced in the bone marrow. And that's really our fundamental mode of treatment. So chemoimmunotherapy is designed to stop the production of these abnormal light chains. And then that gives a chance for the body to then get rid of, slowly in time, the amyloid that's deposited in the organs. But that takes a number of months. And even when you have a great response to treatment, that can take a number of months. Even to get the best response, that can happen over a year. And it does depend on the different organs, and it depends on the amount that has been deposited. So it's not a quick and simple pathway, even when you get really excellent responses to chemotherapy. To make it a little bit more challenging, in the WM world, the type of abnormal cells in the bone marrow are a little bit more complicated. So we kind of think about these in two different forms. The majority is a lymphoplasmacytic lymphoma that we see in the bone marrow if you've got someone with an IgM disorder, and that's treated in a certain way. But less commonly, some people just have abnormal plasma cells in the bone marrow with an IgM amyloidosis, and that's treated preferentially in a different way typically. So I'm going to talk a little about some of the options. So these are options that you will have heard of in the general WM session. So bendamustine and rituximab is a treatment that's reasonably well established, and we know that patients with WM have this treatment if they've got bulky disease or in other situations. And this is a treatment that patients do respond to in amyloidosis. And then we have rituximab with bortezomib, which is a Velcade injection, as well as cyclophosphamide dexamethasone. That's another regimen that may be considered and discussed. And then we have daratumumab more recently with bortezomib, which has been now approved in the UK for the treatment of AL amyloidosis. And that may be considered, particularly if you have a plasma cell predominant disease in the bone marrow. I put a line through ibrutinib because we've talked about a BTKI therapy previously, and it's been disappointing that we've not had good responses in the world of amyloidosis. So typically we don't use ibrutinib. I mean, that may be considered down further lines of therapy if people don't respond to the initial therapy, but typically this is not used on first line because we don't get good deep responses. However, there is some new information that's being collected in Europe with second generation BTKIs with the zanubrutinib, and I think further information will be coming over the coming months. Now, what about autologous stem cell transplant? So there's a poster, excellent. So there's a poster on zanubrutinib today, so I definitely recommend that you look at that and have a discussion with the team. So that's a collaborative effort, and that's really the first experience of zanubrutinib in AL amyloidosis. It's a very rare disease, and we really don't know what the experience of zanubrutinib has been. So there's a really excellent poster that I would recommend you view and have a discussion with the team about, because this is really something that may well be a potential treatment. And certainly that would be very welcome, given that we have some limited options here. We have bendamustine, rituximab, we have bortezomib-based therapies, and more recently, daratumumab-based therapy. Now, what about autologous stem cell transplant? So this is more intensive chemotherapy, and the reality is, in the first-line situation, most people are not fit enough to have really intensive treatment. But it's really something we should think about if patients can get through their initial bits of treatment and become fit enough. Can we give them more intensive treatment as a stem cell transplant? Because potentially that more intensive treatment can keep these abnormal bone marrow cells at bay, and that we know is really the key to treatment. So the key of treatment is getting as low a burden of disease in the bone marrow as possible. I mean, ideally, if we can eradicate it, that would be wonderful. We know it's not it's not something that we can cure, but it's something we can definitely treat. And the lower the bone marrow burden, the better. There are some considerations with bone marrow transplants. I've put the word age then across through it because, again, traditionally people think age is a cutoff as a number that we say, yes, you can have, no, you can't. But actually, that's really not what's considered as the determining factor. Really, in the world of amyloidosis, it's related to your general function, how you are in terms of your organ status. And it's common in the world of amyloidosis that we review this over time with how you respond initially to the first rounds of treatment. And we would hope that patients' performance status and function gets better over time, and then they may be considered for a transplant. Although I would say this is in a minority of cases. I put the heart and the kidneys because really we're quite obsessed with the heart and kidneys in the world of amyloidosis and generally in hematology, because those are the things that really will determine whether you can take more intensive chemotherapy and the strategies going forward. So, next question, I think this is the last question. Are there any clinical trials available for AL amyloidosis?
Very optimistic crowd.
Yes, very good. Okay, yeah, that's so. So again, this is a very rare disease, and we have been lucky. I mean, for many years, it's been very difficult to get clinical trials in this area because it's a rare disease, and collaborating often with a number of different centres to recruit patients in. It has been quite difficult. I mean, there's no specific trials for WM-related amyloidosis, but actually we've managed to recruit a number of patients into clinical trials that have a diagnosis of WM or an IgM-related disorder if they fit other criteria, and if it's not an exclusion, we're very keen to promote trials and try to get people involved. Certainly it should be discussed and thought about in terms of eligibility, I think, with everyone. So wherever you are being treated, I think it's something that you should ask and your team should be talking to you about. Are there clinical trials that are available to me? And, could I be a candidate for it? Now, it may well be that you have a discussion and you prefer not to undergo a clinical trial, which is obviously absolutely fine. But I think it's definitely worth having a discussion, with your physicians about this. So to talk about specifically what the clinical trials we have available. So really we talked about chemoimmunotherapy, which blocks the abnormal cells or targets the abnormal cells being produced. But there have been some antifibril antibody trials, and this is kind of looking at the other end. So these are the fibrils that are deposited in the end organs. Is there a way of clearing these or stopping those in circulation, helping those being cleared by the body itself? And in the UK, we've had a few of those trials open, and currently we have one which is enrolling. Now, it is challenging to get into these trials because you have to fit lots of different criteria. So it's not easy to get on some of these trials, but it's certainly something that should be considered. And more recently, we have another trial that's enrolling, which potentially can include patients with amyloidosis. And this is looking at different types of therapy which could help stop the production of the abnormal cells in the bone marrow. So that's in the UK, but there are other trials abroad. So there are trials potentially in the next in the next year or so that are opening with looking at cellular therapies, which may well be an option in the future. I'm going to talk now about supportive measures. So we often talk about chemoimmunotherapy to stop the production of these abnormal cells, but really I think the mainstay of treatment is supporting the organs and supporting living whilst having amyloidosis. And there's a number of different factors that have to be considered, but those who have involvement of the heart. We always ask patients to check their blood pressure every day, lying and standing, and checking if there's any drops, if there's any dizzy episodes, checking the weight every day, and really keeping a chart of this and discussing this with their physicians quite regularly. Close monitoring of blood pressure and weight is really the fundamentals in terms of management of medications in clinic, but also it's useful for the heart as well as the kidney organs when they're affected. In a number of cases, if you have particularly severe heart involvement, or if you're on certain types of treatment, there are risks of getting a clot, and that's something that we often have to discuss and think about. Do you need to be on blood thinners, or are there other ways that you could use to keep yourself mobile and preventing the risk of a clot? Neuropathy can be challenging in WM generally, but it can be challenging in AL, amyloidosis specifically, and we often need to use certain types of medication which help with neuropathy, dampening down some of the symptoms. And then fatigue, diarrhea and nausea with chemoimmunotherapy, that's kind of standard supportive care we give. And fatigue is a really difficult symptom that can be chronic and that can be exacerbated, particularly in the treatment months. But we've looked over time of patients who have 4 to 6 months of treatment, and fatigue scores and walking test scores will typically be impaired during that period. But we know over the months after treatment, when there's better organ responses and recovery, actually what happens at this stage is fatigue gets better and organs start to slowly recover. So we don't see quick responses, but we do aim to see those over the 12, 18, 24-month time period after treatment. So to summarize, it can be quite challenging in the world of AL amyloidosis because the symptoms are very vast. Delays in diagnosis are quite common because you often present to different specialties and different causes are explored first. And it can seem like the pathway is very convoluted because there's a scan in one department and then there's a test in another department, and actually all these things need to come together in a discussion. But when all these things are put together, there can be a really good tailored treatment plan, and that's really tailored to obviously your lifestyle, your organs that are involved, and then that gets tailored throughout the treatment course. So treatment is often started and then modified over the time period based on how organs are responding and how you're getting on. It is encouraging that there are more treatment options available. We would definitely like this to be expanded over time, but we are encouraged that there are trials that are available, and we are very keen to recruit patients into trials because that gives us more evidence and more understanding of what treatments are best for patients with WM. My takeaway would be to really discuss that, to discuss with the local teams if there are any trials available, and keep an eye out on that. Thank you very much, and I'd like to thank all of the teams that I work with at UCLH, but also at the Amyloid Centre and the trials team. And there'll be a session later, but I'll be happy to talk in the poster session and after this session if there's any questions. Thank you.